Recording. Okay, so hi guys, I'm Hania Nizami. We're going to be doing the second part or the second lecture, Hormonal Changes in Pregnancy. This is my name, this is my number and email in case you guys have any questions or if I did anything wrong. And yeah, just keep answering in the chat like you guys did in the previous lecture if you guys have any questions. So let's start. So before we start, I just want to go over anatomy really quickly because there's something that's very clinically relevant and came up in our OSCE that I want you guys, or OSPE, sorry, and I want you guys to really know about it really well, just in case it comes up for you guys. Although it was third year, but I'm not sure. Anyways, so over here you can see I have a diagram of the pituitary gland, right? What I want you to notice is that the pituitary gland is very close to this structure right over here, which is called the optic chiasm, okay? Optic chiasm. And you can tell by its name that it has optic in it, that it has something to do with vision. Okay, so that's what I want you to know. The pituitary gland is very closely related to something called the optic chiasm, and optic chiasm plays a role in vision, okay? That's the first thing that I want you to know. Because the reason I want you to know that is that imagine if something happens where the pituitary gland is increasing in size by a lot, right? For example, pregnancy. The pituitary gland might increase in size. I'm going to explain why in a second. After the pituitary gland increases in size by a lot, it might start obstructing this optic chiasm, and that's going to lead to visual disturbances, like the bitemporal hemiapnea. Perfect. It's when you have decreased peripheral vision, specifically in both of your eyes. Okay, that happens because of an enlargement of the pituitary gland. Wait, why is the pituitary gland increasing in size in pregnancy? Let me tell you. Remember in the last lecture, I really emphasized to you guys, you need to know that estrogen and prolactin are related to each other. Estrogen stimulates prolactin. What I didn't tell you is how that happens. Basically, estrogen goes to the pituitary gland. It's going to stimulate these kind of cells called lactotrophs, and those lactotrophs produce prolactin. Okay, so the more estrogen there is, the more the lactotrophs are multiplying and dividing, and because they're multiplying and dividing, the pituitary gland is growing in size. It's going to start to obstruct the optic chiasm. It's going to lead to visual disturbances, okay, specifically bitemporal hemiapnea. Okay, that's the first thing. Second thing is that I just said the pituitary gland is increasing in size, right? If something is increasing in size, it needs much more blood supply, right? If something needs more blood supply, if you have something that's going to cause blood loss, for example, giving birth leads to a lot of blood loss, right? This means that this very large organ or this very enlarged organ is very prone to ischemia. Okay, so what I'm trying to say is that the pituitary gland enlarges during pregnancy. That means that it needs a lot of blood. And so during labor, when you're losing blood, it's very prone to ischemia. And that specific syndrome is called Sheehan syndrome. It's basically after delivery, there's a lot of blood loss. The pituitary gland can undergo ischemia. Okay, Sheehan syndrome, perfect. Okay, and if it's going to undergo ischemia, basically all of the hormones that are normally produced by the pituitary gland are going to be decreased. So you're going to see all of those effects. That was the thing that was in our OSPE, and that's what I really want you guys to know. Okay, so moving on from the pituitary gland anatomy for a second, I want to focus more on the thyroid changes that happens during pregnancy. Okay, let's start with the first thing. The first thing that's going to happen during pregnancy is the thyroid binding globulin is going to increase. Okay, I need you to know this. Thyroid binding globulin is going to increase. The role of thyroid binding globulin, this is going to really shock you guys, is that it binds to free T4. Okay, it makes free T4 bound T4. It binds to T4 so that now it can transport it in the blood. Okay, here's what I need you to start thinking about. If I have increased thyroid binding globulin and it's binding to as much T4 as it can, that means that the free or the unbound T4 is now going to decrease, right? Here's what I really, really need you to know. The TRH receptors in the hypothalamus are only stimulated by free T4. In other words, they don't know how much thyroid hormone I have in my body. The only thing they know is how much free or unbound thyroid hormones that I have in my body. So basically what I'm trying to say is that if you increase thyroid binding globulin, the amount of thyroid hormones stays the same. However, because there's more thyroid binding globulin, there's less free or unbound T4. The TRH receptors in your hypothalamus are going to read this as low free T4. They're going to start to think that you're hypothyroid. They're going to think that there's less thyroid because it can only interpret the free T4. Okay, that's really, really important to know. So basically, because your hypothalamus thinks that there's less T4, since there's less free T4, the TRH is going to be stimulated. This is going to lead to more TSH from the anterior pituitary, and the thyroid is going to release more thyroid hormones. Here's what I need you to know. If I were to count the thyroid, the free thyroid hormones, and the bound, yes, the thyroid hormones would be elevated. But if I were to measure just the free thyroid hormones, they would actually be the same as before pregnancy. Okay, so that's a really, really important concept to understand. Does everyone get that? Why the free thyroid hormones stay the same, even though there's more thyroid hormones in my body? Basically, it's because the thyroid hormones are bound. Okay, good. Okay, the next thing that I want you to know regarding the endocrine changes in pregnancy is that I want you to know that estrogen promotes angiotensinogen released from the liver. Okay, it's also going to promote renin released from the liver. Both of these play a role in the RAS system, the renin angiotensin aldosterone system. And what I want you to know is that if we're promoting angiotensinogen from the liver, if we're promoting renin from the kidney, what's going to happen is we're going to get more aldosterone stimulation. And the role of aldosterone is to absorb sodium. And if you're reabsorbing sodium in the kidneys, you're also going to reabsorb water, because wherever sodium goes, water is going to follow. And yes, because you're reabsorbing more water or more fluid, it's going to lead to increased blood pressure. The other way that this happens is that the RAS system, renin angiotensin aldosterone system, the angiotensinogen 2 or angiotensin 2 also vasoconstricts a little bit. But the main thing I want you to know is that it's going to increase sodium and water retention. This is going to lead to elevated blood pressure. That's what I want you to know. That is the role of estrogen specifically. Okay, the pituitary enlarges because there's lactotroph hypertrophy. What hormone is it stimulated by? What hormone stimulates lactotroph hypertrophy? Estrogen. Prolactin is produced by the lactotroph. I'm saying what stimulates the lactotroph. Okay. And then if your pituitary gland starts to increase a lot and you're starting getting visual problems, what are you starting to think is maybe obstructed? Good, optic chiasm. And the last thing is that if a patient comes and she's just recently given birth, she was just in labor, and now she's having, yeah, you guys already know, signs of pituitary ischemia, Sheehan syndrome. Good. Okay, and I didn't mention this, but remember how I told you that there was, well, actually, let's go through this first. First, tell me the TBG, is it going to increase or decrease in pregnancy? Thyroxine binding globulin. Increase or decrease? Increase. What about the free T4 and T3? Increase, decrease, stay the same. Ooh, I saw 2 people say decrease. It's actually wrong. It's actually going to stay the same. Again, it's going to normalize. Is it clear why it normalizes? Because the TRH receptors in the hypothalamus only read free T4 and T3. So as long as those are normal, okay, it's going to stay normal. Good. I didn't tell you is that the reason TBG is increasing is because of estrogen. Okay? Yes, because of the feedback. Exactly. Okay. Now, this is actually from the last lecture, but let's see if you can get it. Remember, I kept telling you that the cortisol that's made in the mom does not pass to the baby because it's going to go to the placenta first. What about HCG and TSH? What about them? I guess maybe you're saying like HCG can also stimulate the TSH receptors. Yeah, that's like also true. That I think also contributes to hyperthyroidism. Yeah, it's not that it increases TSH, is that it stimulates the receptors. So that can also increase the thyroid hormone levels. But that's like a little bit pathological. Like normally you shouldn't, like a pregnant woman shouldn't have symptoms of hyperthyroidism. They can get symptoms of hyperthyroidism because of the HCG is stimulating the TSH, but not every pregnant woman is going to have that. But every single pregnant woman, like physiologically, they are going to have increased TBG levels and they are going to have more thyroid hormone levels, but they're not necessarily going to have symptoms of hyperthyroidism. Does that make sense? Like if something asks about symptoms of hyperthyroidism, I would say HCG stimulation. But if they just talk about the physiology, I would stick to the thyroid bioimmunoglobulin. Okay, yeah, going back to the adrenal gland. Remember I told you that maternal cortisol, it's not going to go to the fetus because first it's going to be stopped by the syncytial trophoblast and it's going to be converted to something. What was that something? What does it get converted to? Doesn't T4 decrease first? Then it goes back to normal. True. If that's what you guys meant by decrease, you're right. The free T4 does decrease first. But I meant like by the time you measure it. Yes, cortisone. And this is the inactive version. Okay, so estrogen stimulates the release of what from the liver? Remember in the last slide I showed you? See, one person said it. Anybody else? Okay, the answer is angiotensinogen. Somebody did say that. And what about from the kidneys? What does estrogen stimulate? Renin. Good. Angiotensinogens from the liver. Renin is from the kidneys. Okay. And then the RAS system is going to lead to the production of this hormone. And this hormone is going to increase sodium retention. What is the name of that hormone? Good. Aldosterone. Okay, so it's going to be increased normally in pregnancy. This is just normal physiology that we're talking about right here. Okay, next we're going to go over the cardiovascular effects of pregnancy. Two things I really want you to know. I've only shown one of them over here, but I'm going to talk about both. I want you to know that systemic vascular resistance is decreased in pregnancy. Basically, what that means is that the blood vessels are going to be modified in a way that they're more compliant. They're going to be bigger. They're going to be able to hold more blood. Okay, so I want you to know that systemic vascular resistance decreases. Second thing that I want you to know is that you're going to have more fluid retention. We already talked about why. Aldosterone is going to increase the sodium reabsorption. It's going to lead to more fluid. So both of these things inside of a pregnant person, the sort of like very compliant blood vessels, plus I have more fluid inside of these blood vessels, are going to make the blood vessels like very, very enlarged or engorged. And that's why you might have heard before, you might have even seen like pregnant ladies in their legs, you might actually be able to see their veins. And that's called varicose veins. And it's basically because there's so much fluid and the veins are so compliant that you can actually see them from the outside because they're so engorged. So that's the two things I want you to know. SVR decreases and you're getting more fluid on top of that. You have increased blood plasma. That's one thing that I want you to know. Second cardiovascular thing that I want you to know. Okay, we talked about increase in plasma volume, right? More sodium water retention. We talked about that. There also is an increase in red cell mass. You can see that there is an increase. However, and I need you to pay close attention, in pregnancy, there's something called dilutional anemia. You're like, that doesn't make any sense, Hania. You just told me that the RBC mass is increasing. Why am I getting anemia? It's because what we classify as anemia isn't the amount of RBCs that I have in my body. It's actually the percentage or the ratio of RBCs to plasma volume. So basically what's happening is that look at how much plasma volume is increasing by compared to how much the RBC mass is increasing by. The RBC mass isn't increasing as high of a rate. And so the ratio of RBC to plasma volume is going to be low. And this leads to anemia in pregnancy. RBC mass increased, but not increased as much as plasma volume. This leads to dilutional anemia. That's what I need you to know. Okay, so cardiovascular changes. I told you that something decreases in pregnancy. Something happens to the blood vessel. Decrease in SVR, good. And increase in total body volume, good. So you can imagine, if you guys remember I think you guys have taken CBP by this time, both of these factors are going to increase cardio output, right? Because less resistance means more blood can leave the heart. That's going to increase cardio output. At the same time, you have more fluid entering into the heart. And if you guys remember, there's like the stretch receptors. And if those receptors are stimulated, they're going to pump even harder. And so it's going to increase the cardiac output. So again, decrease in peripheral resistance, increase in plasma volume. Both of these things increase the cardiac output by quite a bit. Okay, I talked about the peripheral resistance decreases because there's change in the vessels, right? Low resistance, highly compliant vessels. Okay, what happens to the RBC mass? Increase, decrease, stay the same. Increases, good. What about like the hemoglobin concentration? Concentration. Decreases, good. It's a really high yield thing to know because of dilutional anemia. I already talked about how this is going to lead to bloating and edema because the vessels are just so compliant and they're so full of fluid. Some of it can actually leak into the extracellular fluid compartment, and that's what we call edema. Edema is the presence of fluid in the extracellular fluid compartment. Okay, this clinical box over here, I'm actually going to show you in the next slide. But basically, because the uterus is growing and it's really heavy, when a pregnant lady lies on her back, especially during the later trimesters, the weight of the fetus can actually compress the inferior vena cava. And what happens if you're compressing the inferior vena cava is that all of the venous blood that's supposed to be draining from your legs up to the inferior vena cava, it can't return, right? Now it's being compressed, so now the venous blood from your legs can't go. So it's going to stay in the lower limbs, and it's going to lead to the varicose veins that I talked about before, or the edema. Basically, the venous blood from the lower limbs can't go up anymore because the inferior vena cava is compressed. Similarly, because there's no venous blood going from the lower limbs back into the heart, this can actually decrease blood pressure because my heart is losing blood that it can pump, that it should normally be pumping, right? So this can lead to hypotension because there's less venous return to the heart. I'm going to show you that in the next slide over here. Yeah, you can see this is the pregnant lady. She's lying on her back. So the weight of the fetus can actually compress the inferior vena cava. That means that everything below the inferior vena cava is going to engorge, and that the blood that's supposed to be going to the heart is limited, and this can lead to hypotension. So one of the recommendations during pregnancy is you just tell them to lay on their side. Speaking of a fetus growing and increasing intra-abdominal pressure, there's two things I want you to notice, okay? The first one I'm going to focus more on is the lungs. Look at this fetus really increasing the intra-abdominal pressure. It's actually pushing the diaphragm up a little bit. Now, because the fetus is growing and it's pushing the diaphragm up a little bit, my lungs can't expand as much as they could before, right? In other words, the residual volume, what residual volume is that after I take a breath out, like after I exhale, that air that's left inside my lungs, I call that residual volume. It's sort of like the leftover air inside of our lungs, okay? There's going to be decreased residual volume because there's literally less space for my lung to expand. Hopefully that makes sense. Okay, that's the first thing that I really want to focus on with the lungs. Second thing, I just want you to take note of it right here. Just notice the stomach is also being compressed. I'm gonna go over that later when I get to the GI part, but just take a moment to appreciate the fetus is compressing the stomach as well. But mostly focus on the diaphragm right now, how it's compressing the lungs. My lungs don't have as much room to expand. Okay, going back to the lungs, we already talked about the residual volume. This is a normal person over here on the left-hand side. This is a pregnant person. You can see over here in normal people, I have more residual volume. Residual volume, again, is just the leftover air in my lungs after I exhale. As you can see, it goes from this amount over here to about this amount over here. Okay, so there's less air in my lungs. That's basically what I'm trying to get across. Here's where things get a little bit confusing, so stick with me. Yes, there's less functional residual capacity. However, if you were to measure how deep of a breath a pregnant lady is taking compared to a normal person, they're actually taking deeper breaths compared to you and I. Okay, so that's called the tidal volume. Tidal volume is basically how deep of a breath am I normally taking. Okay, so this is a normal person. This is about how much it is. And look at a pregnant lady. It's actually more. The tidal volume, or how much they breathe with how much air they're taking in and out with each breath, is actually more. I'm going to explain why on the next slide. Okay, I know this graph kind of sucks, but it's the best one that I could find. The main thing that I want you to look at, okay, so just pretend this bottom axis is CO2, and this y-axis is the ventilation rate, aka like how deep of a breath or how frequently they're breathing. What I want you to know is that, so this is the normal person, these white dots over here. This is a pregnant lady over here. So let's say I have like about like, I don't know, like 48. That's kind of high, but let's just pretend for the sake of this graph. Let's say there's 48 partial pressure of CO2 inside of my blood. For me, my ventilation rate is only going to be about like 12, let's say. These numbers aren't accurate, but I'm just trying to explain the concept, okay? My ventilation rate is only going to be about 12. Compared to a pregnant lady, she's going to be ventilating a lot more. So the same amount of carbon dioxide is inside of me and it's inside of her, but she's going to be breathing much deeper and much more frequent breaths. Basically, the main idea I want you to get in your head right now, pregnant people do not want carbon dioxide inside of their blood. They do not want carbon dioxide. What are they going to do to prevent carbon dioxide from being inside of their blood? They're going to start breathing deeper and breathing more frequently so that they can expel all of that carbon dioxide, okay, so that they can breathe it out. So that's why their tidal volume is increased, okay? Or at least that's a way to remember it. Okay, last thing, let's just go over the renal one. This is pretty intuitive, really easy. So right over here, I have my afferent arteriole. Pretend this is my glomerulus. This is my efferent arteriole. Imagine I have increased blood pressure and I've increased blood plasma. Of course, because I have so much pressure over here in my glomerulus, it's going to increase the GFR, and that means that more fluid is going to be moving from my blood vessels to my kidneys, or entering into my kidneys. That's what I want you to know. GFR increases because just I have so much fluid inside of the body. Of course, more of it's going to go into the kidneys. Okay, because I have such a high pressure or such a high GFR, what's going to happen is I can have a little bit of leakage of things that like normally aren't present inside the kidneys, or normally aren't excreted by the kidneys at least. Specifically, what I'm talking about are amino acids, which we call amino aciduria, presence of amino acids in the urine, or glycosuria or glucosuria. So basically, pregnant ladies normally have, physiologically speaking, they have glucose in their urine. Okay, unlike me and you, we normally should not have glucose in our urine. It's because they have so much fluid inside of their body, and because their blood pressure is increasing, more of it is going across into the kidneys. And because so much of it is going to the kidneys, not all of it can be reabsorbed. So some of it is just going to be lost in the urine. Okay, I know that was like a wall of information. So we're going to try to quiz ourselves, and I hope everyone could keep up. But yeah, as pregnancy proceeds, the functional residual capacity and the residual volume increase or decrease? Decrease. Perfect. Now, what about the minute volume or the tidal volume? Increase or decrease? Increase. Really good job, guys. Exactly. Deeper breaths. And the reason that they're doing that is they don't want carbon dioxide. They want to expel as much carbon dioxide as they can. Okay, so we had the growing fetus. I show you do the diagram. It's going to increase intra-abdominal pressure. What does that do to the diaphragm? How does the diaphragm move? Yep, up, rises. Exactly, pushed up. This is just, I guess, like sort of an intuitive fact, but because the fetus is growing so much, it's obviously going to need oxygen and it's going to be producing more CO2. So remember I told you that she's really trying to get rid of that CO2. Where is that CO2 coming from? It's coming from the fetus, and the fetus also needs oxygen. So that's another way that you could remember tidal volume. Is it bigger or smaller? It's bigger because I need more oxygen for my fetus, and I need to be expelling the extra CO2 that this fetus is giving me, right? So this is a little bit hard, but try to think. So progesterone is going to go to the CNS, and what is it going to do for the set point of CO2? So basically, is it going to increase the threshold of CO2 inside the body, or is it going to decrease the threshold of CO2? Good, decrease. Yeah, don't doubt yourself, no question mark. It's going to decrease the set point, and basically what we're saying is that it's going to tolerate less CO2. I want less CO2 in my bloodstream. Okay, last one, pretty easy. What happens to GFR? Increase or decrease? Increases. I think one person said decrease, but GFR is how much of the fluid is going from the blood vessel to the kidney. And again, because I have higher blood pressure and because I have more fluid, more of the fluid is going to move from the blood vessels to the kidney. That's going to increase GFR. Okay. Because I have increased GFR, what could end up in my urine? That's not normally present in me, but might be present in pregnant. Good, glucosuria. This is actually, you don't need to know this as a second year, but this is actually pretty high yield to know because you guys know that bacteria like glucose, right? So basically what happens is that because there's glucose normally present in the urine, it predisposes them to having a UTI, a urinary tract infection. Because they have all this like nice sweet glucose inside their urine, it really creates a nice environment for bacteria. And that's why pregnant people are very prone to UTIs. You don't need to know that, but that's just sort of like a fun fact. Okay, now we're done with cardiovascular and renal. We're going to move on to the GI physiology of pregnancy. Okay, remember I told you, look at this. I have my fetus, it's growing. It's really compressing the stomach of the mother. Okay, if I'm compressing the stomach of the mom, what happens is that acid that's normally present inside the stomach is going to go up a little bit. And we call this acid reflux. Okay, so because the stomach is being compressed, the mom might have acid reflux. That's one mechanism of acid reflux in pregnancy. The second mechanism of acid reflux in pregnancy is increased progesterone. Basically, the progesterone is going to act on the sphincter right over here. It's called the lower esophageal sphincter, and it's going to relax it. Progesterone is going to relax the sphincter right over here. Because it's relaxing the lower esophageal sphincter, now the sphincter is relaxed, it's open, and now more acid can go from the stomach up to the esophagus. So this is, again, promoting acid reflux. Those are the two things. It's being compressed. It's also the sphincter is being relaxed. Okay. Actually, don't remember what the first one is. Okay, yeah, the high intra-abdominal pressure increases intragastric pressure, causing what? What happens now that the stomach is compressed? Acid reflux. Perfect. Okay, what hormone relaxes the lower esophageal sphincter? Progesterone. Good. And this is, again, going to increase reflux. And one of the symptoms for that is just heartburn. Like after they eat, especially a really long meal, they might feel a little bit of like a burning sensation in their chest. Okay, I didn't talk about it in this lecture, but in the previous lecture, you guys already know that there's insulin resistance You guys actually know one step beyond that. You know that it's because of HPL. What happens to insulin? Increase or hyper or hypo? Okay, I see one answer. Good. Everyone's getting it. Hyperinsulinemic. And no one should say, oh, it's hyperinsulinemic. It's going to lead to hypoglycemia. No, because there's insulin resistance. So it doesn't matter that there's high insulin. Okay. Okay. Maternal. What do they use for energy? Glucose, proteins, what? Fatty acids. Good. Free fatty acids specifically. What do they not use? Because they want the baby to use it. Glucose. Good. And we already talked about this. Increased insulin secretion because there's more glucose. Beta cell hyperplasia releases more insulin, but the response to insulin is less. There's insulin resistance, in other words. We talked about how this is going to contribute to gestational diabetes. It's a very similar mechanism to type 2 diabetes, somebody said, and I think that's really true. Okay, what hormones are responsible for these diabetes? Okay, one, good. You guys said HPL. That's the most important one. Prolactin is another one. Progesterone is another one. There's another one. Try to think what increases glucose. What hormone do you normally know, especially in response to stress, increases glucose? Talked about in the previous lecture. It's cortisol. Yeah, I know I didn't mention it in the context of diabetes or gestational diabetes, but you do know that the fetal adrenal cortex is making cortisol. You know that there's CRH coming from the syncytial going to the maternal blood circulation, increasing cortisol. And you do know that cortisol increases blood sugar. So it should make sense that because cortisol is increasing blood sugar, it's going to predispose the patient to diabetes. But again, in my personal opinion, the most important is HPL. But yeah, it is important to know prolactin, progesterone, and cortisol. Glucagon also does, it's just not responsible for diabetes. Like it does increase the blood glucose. Okay, moving on. Let's go through this is a little bit of a haphazard lecture, but the next thing that he wants to cover are the 3 stages of labor. Basically, the main things I want you to know, first stage of labor is when the fetal head makes contact with the cervix. Okay, that's the first stage, is the fetal head making contact with the cervix. Second stage of labor is the actual delivery of the fetus. So once you start the crowning, I believe at 10 centimeters dilated of the cervix, up until you have that fetus outside of the body, that is the second stage. The third stage is actually called afterbirth sometimes, and it's the delivery of the placenta. Okay, first one is the fetal head making contact with the cervix. Second head is the delivery of fetus. The third stage is delivery of the placenta. That's what I want you to know. Let's go through that. What's the first stage? It's the force of the fetus against against what? Good. See 2 answers. Okay, cervix, good. Second stage is delivery of the yes, fetus. Third one is the delivery of the placenta. Perfect, guys. Okay. Remember in the last lecture, I told you there was something that was a little bit confusing regarding the whole ACTH thing. Like, yes, CRH does come from the hypothalamus, but it also comes, exactly, yeah, the answer is CRH. I kind of already spoiled it, but it also comes from the placenta. Okay, so the placenta produces CRH. It can go into the maternal bloodstream, stimulate the anterior pituitary to secrete ACTH. ACTH goes to the adrenal cortex, makes cortisol. Okay, so yeah, the CRH stimulates what secretion? I know I just said it on accident, but CRH goes to the anterior pituitary to secrete what? ACTH. Yes. And then it's cortisol. Good. Here is something very important. So forget the CRH from the hypothalamus for a second. Just imagine in your head the diagram of the CRH from the placenta, okay, specifically from the syncytiotrophoblasts. This CRH actually has a positive feedback loop. It's the complete opposite of what's happening normally inside mine and your bodies right now. It's a positive feedback loop. In other words, if the cortisol from the mother increases and goes to the placenta, the CRH is going to increase even more. So it goes back to the mom, increases the cortisol even more, and you just have increase of cortisol throughout pregnancy. And for me, if you think about that, that kind of makes sense. Because what's the whole point of increasing cortisol? The point of increasing cortisol is so that you reach labor, right? You want to increase the cortisol or the CRH so that you get more and more myometrial contractions. The more and more myometrial contractions you're having eventually is going to lead to labor. It's going to lead to the delivery of the fetus, right? Versus, for example, mine and your bodies, we don't want a positive feedback loop. That means that when I get stressed, I'm just going to get more and more stressed. I don't want that. I want to make sure that my body is keeping my stress hormone level at a certain amount. But that's not the goal in pregnancy. The pregnancy is that you want to increase hormone levels so that it eventually leads to expulsion of the fetus. So again, it wants to increase myometrial contractions more and more the closer and closer we're getting to labor. And the part of the way that it does this is that you guys should know, and I'll go into a little bit more later, is that oxytocin and prostaglandins both play a very important role in myometrial contractions. I'll go into that more later, but again, oxytocin and prostaglandins play a very important role in myometrial contractions during labor. Okay. Oh yes, in the fetus, what is cortisol important for? Maturation of the, yes, one person said it. Anybody else? Lungs, yes. Cortisol is really important for fetal lungs. And that is really clinically important because sometimes if a baby is born preterm, aka they're born a little bit too early, their lungs didn't have enough exposure to cortisol. And so it's really interesting. What you do is you just give it to them. You just make them take in a little bit of cortisol after they're born. So I really want you to remember that cortisol is really important for the maturation of lungs. And I also want you to know the GI system, but in my opinion, the lungs is more important. Okay, so remember in the previous slide, I was like, oxytocin is so important for labor. It's so important specifically for myometrial contraction. That's what we're going to go over right over here in this diagram. Here's what I want you to know. During labor, I want my contractions to get more and more frequent, right? Because the more frequent they are, the more likely that I am to expel the fetus, right? So basically what's happening is that I would start over here, is that this is my baby and it's growing, right? Because the baby is growing, it's going to stretch the cervix, this part right over here. Because the cervix is being stretched, this is going to stimulate the posterior pituitary gland to release oxytocin. What oxytocin is going to do is that it's going to make the myometrium contract. Now, if the myometrium is going to contract, guess what's going to happen? The baby is going to stretch the cervix again. And because the baby's stretching the cervix, it's going to release more oxytocin, and now we're contracting again. So again, this is a positive feedback loop. It's different from what you learned about before. This is a positive feedback loop. I'm basically trying to get more and more contractions for the baby to eventually lead to delivery. Okay, and this is mediated by oxytocin. I hope you guys are paying close attention. Does this happen at the same time as the cortisol loop? This oxytocin loop is like literally during labor. Versus it's mostly during labor. Cortisol loop, I would say, is probably a little bit earlier than this. That's what I think. But yeah. It's mostly during labor. I lost my train of thought. Oh yeah, what I want you to notice is that the oxytocin is specifically acting on the myometrial cells. It's specifically acting on the muscle cells. Okay, I want you to notice that because it's going to get important a little bit later. Okay. Okay, I know I didn't mention this recently, but does anybody remember the hormone that increases the sensitivity of oxytocin receptors? This is kind of a hard question, to be honest. Nice. Yeah, it's estrogen. Okay, now what hormone is released in response to the stretch of the cervix? Oxytocin. And remember, it's a positive feedback loop. And you can say over here, they say oxytocin is sometimes used to induce parturition. Parturition is the delivery. And so, yeah, it terminates a childbirth. I would say it's mostly really present during the actual labor part, like the active phase of labor. The other thing that they want you to know is that right before delivery, or like as labor is going on, the uterine sensitivity, uterine is very sensitive to oxytocin. That's something that you want to know. And it just kind of makes sense. And it's why when we want to induce labor, we can just give them oxytocin. That's going to increase the contractions because the uterus is very, very sensitive to it. Other thing I just want you to be aware of is that prostaglandins also play a role in the uterine motility or the contractions that also could be used to induce labor, play kind of like a similar role to oxytocin, basically. And yeah. Okay, moving on from the uterus, let's take a moment to look at the breast or the breast changes during pregnancy. Okay, this is the breast over here. I want you to notice this entire section over here is what we call a lobe. Okay, could you explain cortisol loops again? Yeah, I can explain cortisol. I don't think I have a diagram for it, but basically what's happening, if you remember in the previous slide, maybe I can draw. I think I can draw. But if you remember in the previous lecture, I had CRH being made from the placenta, right? Basically what's happening is the CRH is the cortisol releasing hormone from the placenta is going to go to the mom, and the CRH is going to go to the mom, and it's going to stimulate the anterior pituitary gland to release ACTH in the mom, and the ACTH is going to go to the maternal adrenal cortex to secrete cortisol. This cortisol in the maternal bloodstream is going to go back to the placenta. The increased amount of cortisol is going to stimulate CRH. There's going to be more CRH from the placenta, and the placenta again is going to go back into the maternal bloodstream, go to the anterior pituitary, increase ACTH, increase cortisol again. So it's just a positive feedback loop. Does that make sense? It goes from the fetus to mom back to fetus? No. It goes from placenta to mom back to placenta. Remember, I told you the fetal cortisol and the maternal cortisol, they do not interact with each other. There's the placenta in between them, and the placenta is going to make sure the cortisol from the baby stays in the baby and the cortisol from the mom stays in the mom. How does it do that? It's going to convert cortisol to cortisone. So yeah, it's placenta to mom, placenta, not placenta to baby. Does that make sense? Okay. No? Okay, yeah, so going back to the breast, we have a lobe of the breast. Lobe is made of a lobule. This is a lobule. There's about like 20 inside of a pregnant breast. And then the lobule is made of these grape-like clusters, and we call these grape-like clusters alveoli. Kind of like the same thing that you call in the lungs. They're called alveoli. Except the role over here is that the alveolar epithelial cells are responsible for secreting milk. Okay, so each of these alveoli, they're going to secrete milk. Here is something that is so important for MCQ questions, in my opinion. You have to know that these alveoli secrete secretory epithelial cells that are producing milk. The milk production is from prolactin. Again, lactin means like lactose, it means milk. The milk production is from prolactin. Surrounding the epithelial cells are actually myoepithelial cells. There's actually muscle cells, they didn't draw over here, surrounding the epithelial cells. These myoepithelial cells are going to contract, they're going to compress the alveoli, they're going to move the milk down to the ducts. This mechanism that I just described is from oxytocin. Oxytocin contracts myoepithelial cells around, and the contraction is going to move the milk. But the actual production of the milk is from prolactin. It's a really important distinction between the two. And again, if you're ever confused and you're like, OMG, which one does which? If you remember that oxytocin acts on the muscle cells in the uterus, it should make sense to you that oxytocin is going to act on the muscle cells of the breast. Okay, so that's it for this slide. We have, again, like the lactiferous ducts. Sometimes they call this the terminal ducts. This is where the milk is going to go. It's going to go right over here in the sinus. The sinus is actually sort of like a reservoir of milk before it's going to be ejaculated from the nipple. Okay, we talked about this. The mammary gland has about 20 lobes, and each of the lobes has lobules. What is the secretory unit of the lobule called? That grape-like type thing. See one answer? Yeah, alveoli. And where does that drain into? What do you call the thing that it drains into the milk? Ducts. Good. Okay, remember I told you the myoepithelial cells, they contract in response to what hormone to expel milk? Oxytocin. Good. And then, yeah, they're just telling you that surrounding these lobules are going to have some tissue matrix, some fat. This is also, I guess, kind of interesting, is that in response to sympathetic stimulation, there's protrusion of the nipple, and this helps the baby suckle. Okay, I know this slide seems kind of like intimidating. The only thing I want you to know from this is that adipocytes contain an enzyme called aromatase, and aromatase produces estrogen. That's all I want you to know. So basically what's happening is that during pregnancy, I'm having more fat inside of the breast, right? Because I'm having more fat inside the breast, there's going to be more of aromatase. Aromatase is going to make more estrogen. So basically there's more local estrogen production in the breasts because of the adipose tissue. That's all I want you to know. And in case you guys want a silly little way to remember what aromatase does, the way that I would remember this, again, it's just very silly, is that I would think aroma means that it smells good, and it's creating estrogen, and estrogen is found in girls, and girls smell good. That was just a silly little way that I used to remember that. Aromatase makes estrogen. That's what I want you to know. And it's found in adipocytes. Okay. Here is something kind of interesting. So look at pregnancy, and then we're looking at birth, and we're looking at postpartum, right? If you look at that during pregnancy, prolactin levels are really, really, really increasing. And you might think to yourself, wow, prolactin levels are so high during pregnancy, but pregnant women never breastfeed, or they never are able to produce breast milk. Isn't that kind of weird? Like, how do they have such high levels of prolactin? This should be creating a lot of amount of milk, but they're not. While they're pregnant, they're not making any milk. The reason for this is actually because of progesterone. Progesterone is also very, very high during pregnancy, right? And basically, progesterone is going to antagonize the effects of prolactin. Okay, so even though there's very high levels of prolactin, progesterone is going to inhibit the milk producing aspect of prolactin. That's what I want you to know. And so when you look at this, you should look at progesterone, and you should notice that there's a really steep drop. After birth happens, there's a really steep drop. Basically what happens is that because there's less progesterone, there's less inhibition of prolactin, and now prolactin can actually be making the milk. That's what I want you to know. Okay, estrogen, is responsible for breast growth, basically, or ductal growth. I told you that adipose tissue also increases in the breast during pregnancy. What was the name of the enzyme that produces that local estrogen? Aromatase. Good job, guys. Okay, and then the last one, estrogen acts in the breast directly and also indirectly through increasing maternal pituitary blank production by lactotrophs. What's the hormone? What's the name of the hormone? Prolactin. Yeah, again, I really want you to know estrogen promotes prolactin. It's really, really important. Okay, and what hormone inhibits milk production during pregnancy? Good, progesterone. Okay, here's another thing. The first time that a woman is going to breastfeed, she's actually going to create this thing right over here called colostrum, which people call liquid gold. You can see it's very, very fatty. This is the first time a woman breastfeeds. Basically, what colostrum is, and the reason that it's called liquid gold, is because it's really, really good for the baby, and it has antimicrobial and anti-inflammatory properties. Basically, the mom is going to breastfeed this baby a lot of protective things so that they don't have any infections and stuff, specifically antimicrobial and anti-inflammatory. And then after the passage of colostrum, then we have just the normal breast milk. So again, in the very beginning, you actually have colostrum, and colostrum is really, really, really good for the baby. Okay, so I know this might look a little bit intimidating, but if we go on the left side over here, you actually already know this part. Oxytocin does what to the breast? Concentration of what kind of cells? Increases the concentration of good myoepithelial. That's the contraction, and that's going to move the milk. It's not going to produce it. And what they want you to notice is that suckling, the baby suckling at the breast is actually a positive feedback loop. Again, we have this really recurrent theme of positive feedback loops in pregnancy. So if the baby suckles, it's going to increase the oxytocin even more, and that's going to allow for more milk. Because there's more milk, the baby's going to continue feeding, continue suckling. There's going to be a positive feedback loop. And that's why it's really, really important that the mom has to continue breastfeeding. If she takes a break, you're stopping the positive feedback loop, and it's really hard to resume. So you kind of have to continuously breastfeed. That's one thing. Let's go to this part over here. Remember, I told you prolactin makes the milk. Galactopoiesis means I'm actually making the milk, okay? That's what I want you to notice over here. I want you to also appreciate it's another positive feedback loop. So oxytocin is a positive feedback loop, so is prolactin. The more milk the baby's going to drink, the more it's going to stimulate prolactin release, sorry. Here's what I also want you to notice, because it's a little bit tricky. I don't know if you guys have covered it before, but normally when the hypothalamus releases something to the anterior pituitary gland, it's like something releasing hormone. You know what I mean? Like it's like growth hormone releasing hormone, gonadotropin releasing hormone. It's something that stimulates the anterior pituitary gland. I want you to know prolactin is an exception to this. Prolactin is actually inhibited by something from the hypothalamus. It's inhibited by dopamine. Okay, so the more dopamine there is, the less prolactin. So you can imagine in this positive feedback loop of suckling, you're actually going to decrease the dopamine release from the hypothalamus in order for decreased inhibition of prolactin, which is going to increase prolactin. So I do want you to be aware of that. Dopamine inhibits prolactin, and it's sort of a little bit of an exception, right? The last thing that I want you to notice over here is that prolactin plays a really important role where it's going to suppress the GnRH release. Could I repeat that? Yeah, I just want the bottom line, hypothalamus releases dopamine. Dopamine inhibits prolactin. So if you're thinking I want to increase prolactin, that means that I need to decrease dopamine. Is that clear? I just want you to know dopamine inhibits prolactin. Dopamine from the hypothalamus. Is that clear? Okay. Okay, yeah, so going back to the prolactin, it also plays another role where it decreases the GnRH. GnRH stands for gonadotropin releasing hormone. Gonadotropin. Gonadotropin, gonads, sex. So we're talking about sex hormones over here, right? So what's happening is that if increased prolactin is decreasing the amount of sex hormones, right? This is going to decrease menstruation. In other words, it's going to lead to amenorrhea. I'm going to phrase that again, or I'm going to try to explain that again. Basically, prolactin is decreasing GnRH. Because there's less GnRH, there's less LH and FSH. Normally, remember, LH and FSH need to develop the follicle. They play a role in developing the oocyte or the ovarian follicle. because they're decreased in this case, there's not going to be a developed enough ovarian follicle. Because there's no ovarian follicle that's developed, you're not going to have any period, right? Or you're not going to menstruate. Does that make sense? How prolactin leads to amenorrhea? Because it decreases GnRH. Okay. Okay, I told you that parturition, the first time a woman is going to breastfeed, she's going to release colostrum. It's rich in what? Something for the baby. Good, antimicrobial. Okay, at parturition means like delivery or labor. Decrease in placental blank causes breast milk production in a few days. Yes. Decrease in progesterone. Okay. What hormone is responsible for galactopoiesis, or the production of the milk? Prolactin, good. Remember that it's a positive feedback loop with the suckling of the nipple. And then what about prolactin is going to go back up to the hypothalamus and decrease or inhibit which hormone? Oh, GnRH is also correct, actually. That's a good one. I was thinking dopamine. But yeah, GnRH is also correct. Okay, what about, how does it cause lactational amenorrhea? It inhibits what hormone? Someone just said this, but I want you to say it again. Good, GnRH. GnRH, less GnRH, less LH, FSH, no development of the ovarian follicle, no pregnancy, no period. And basically what I think he wants you to know is that even though there's no menstruation, or theoretically there shouldn't be any ovulation or oocyte or whatever, it's not recommended that you only rely on breastfeeding as a form of contraception. Because it's like, maybe you're not breastfeeding enough to decrease the GnRH. You know what I mean? Like maybe your prolactin levels aren't high enough. So it's usually not recommended as a sole form of contraception. Another thing that's very interesting, I don't know if you guys have watched The Office, but there's a scene in there where Pam, she hears the baby crying and she actually starts to release breast milk. You might have seen it in other movies or something like that. Basically what they're telling you is that oxytocin can actually not only be stimulated by the suckling, but it can also be stimulated by psychogenic stimuli. Just hearing a baby cry could also stimulate the oxytocin, which is pretty cool. Okay, now we're going to go on to the APGAR scoring. I think they just want you to be aware of what this is. APGAR scoring is basically, it's a maximum of 10 points. APGAR in itself is an acronym. It stands for appearance, pulse, grimace, activity, respiration. And all that is that for each of these criteria, you either score them 0, 1, or 2. And then you add it all up in the end. Okay, so if somebody's like a very healthy baby, they're going to get a 10 APGAR score. If somebody's a very unhealthy, probably already dead baby, they're going to have an APGAR score of 0. And you measure this specifically at the 1st minute and the 5th minute of life. Okay, and usually it increases. Like, for example, APGAR score of 8 at 1st minute, and it might go up to like 10 at the 5th minute. I think just what they want you to know is that the cutoff for a concerning baby or somebody that might not need to be examined more closely is 7. So basically, if you score the baby and the total score that you get is less than 7, then this baby needs to be admitted to the hospital. This is a sick baby. But if it's 7, 8, 9, or 10, then that's okay. That's considered a healthy baby. Okay, now we're going to move on. Basically, we're going to talk about the formation of twins. I'm going to talk about the easiest one first, which is dizygotic twins. These are also called fraternal twins. You can basically just think of fraternal twins as sort of like siblings that happen to be born during the same pregnancy, because it's 2 separate eggs and it's 2 separate sperm. Okay, like there's no division, nothing like that. It's literally, they share the same amount of DNA as siblings do. It's just that they happen to be born at the same time. That's what I want you to know about dizygotic. 2 separate eggs, 2 separate sperm. in case you're wondering, like, where the heck did the second egg come from? I think sometimes what happens is that because we have two ovaries, sometimes both ovaries can release an egg and both eggs can get fertilized. I think that's why it happens. Okay, so that's dizygotic or fraternal twins. These are ones that don't look alike. They just look like siblings kind of thing. Now let's go on to monozygotic identical ones. This can be broken down into three categories. What I want you to be aware of, or what I want you to be really looking at over here, sorry, is that the earlier that a twin or an egg divides, the more independent or the more separate the twins are going to be. Okay, so the earlier that they divide, the more separate or independent the twins are going to be. What do I mean by this? So for example, if the twin divides, or the eggs, sorry, divide before the morula stage, okay, so now I have two of the same cells, what's going to happen is that they are going to have their own placenta and their own amniotic sac. And we call this dichorionic, diamniotic. Chorion means placenta, remember? So dichorionic, diamniotic. However, if it goes on a little bit longer, right, and a morula is formed, and now they're separate, now I have a monochorionic diamniotic. In other words, now they're starting to merge a little bit more, and now they share a placenta, okay, because they divided a little bit later, so they're going to have more in common now. Monochorionic diamniotic. Just in case anybody gets confused, because I used to be like, wait, is it monoamniotic dichorionic or is it monochorionic diamniotic? The way that I would recommend looking at this is that if you look at this cell over here, right, or this embryo or whatever, if I try to like draw a line down the middle, I can only, if I draw a line down the middle, there's no way that I could separate the placenta from each other without separating the amniotic sac, right? Like if I draw a line and I want to separate the placenta, I have to separate the amniotic sac. Like if I'm just drawing a line all the way through. However, for the amniotic sac, because it's on the inside, you could separate the amniotic sac, again, because it's the inner one, without necessarily separating the placenta. So I don't know if that helps, but that's how I remember that it's monochorionic diamniotic. And again, that just means that they share placenta, and this happens after the morula stage. But they have two different amniotic sacs. Lastly, if it divides after the blastocyst stage, they're going to share both. They're going to share a placenta and they're going to share an amniotic sac. And this is called monochorionic monoamniotic. What I want you to know is I want you to remember before morula, after morula, after blastocyst. I want you to remember which one belongs to each. Before morula, they're independent. They have their own placenta, own amniotic sac. After morula, they share placenta, but they have their own amniotic sac. Blastocyst, they're completely together, okay? They share placenta and they share an amniotic sac. In this case, if they share both things, there's actually a risk that they could be conjoined or conjoined twins. Okay, so what do you call the kind of twins that have like completely different, two sperm, two eggs, two zygotes? What do you call those twins? Good. Fraternal or dizygotic. Okay, what about over here? If they separate before the morula, what are they? Dichorionic, monochorionic, diamniotic, monoamniotic. Dichorionic, diamniotic. Good, because they separated very, very early. They're going to be independent. You can also call these di twins. Okay, the next one, if they separate after the morula, what is it? Monochorionic, diamniotic. Good, yes. And then, good. And then what about the last, if they separate after the blastocyst? Exactly, mono. And if they're mono, what's the risk? What's like a possible complication? Conjoined, exactly. Good. Okay, now let's go on to menopause. Basically, what I want you to know about menopause is that in menopause, there's going to be less ovarian follicles, okay? Or I should say less functioning ovarian follicles, okay? Because I don't have a functioning ovarian follicles, I can't produce estrogen. Because there's low estrogen, feedback loop, I'm going to increase my GnRH. Increased GnRH is going to lead to increased LH and FSH. This is the most important thing to remember with menopause. This is actually how you diagnose menopause, is very high levels of LH and FSH. Why are those levels so increased? Because I'm having low estrogen, because I don't have any functioning ovarian follicles to produce that estrogen. So no matter how high this LH and FSH goes, does not matter. The body cannot produce estrogen because there's just not any more ovarian follicles. Okay, so in menopause, what happens to the estradiol concentration? Increase or decrease? Decrease. What about FSH and LH? Increase. In terms of, we call this secondary amenorrhea. In case you're wondering, primary amenorrhea is when somebody has never gotten their period in their entire life. Secondary means that they got their period and they stopped having their period after a while. But yes, very high levels of FSH and LH. Most important thing to remember for menopause, in my opinion. Okay, here's something else they want you to know. Estrogen actually increases the risk of breast and endometrial cancer. So the more exposure to estrogen I have in my life, the more risk I have for breast and endometrial cancers. And this should kind of make sense to you because think of what cancer is. Cancer is uncontrolled mitosis, right? And we already know estrogen stimulates breast growth. We said that like 10 times during this lecture. We also said estrogen stimulates endometrial growth, right? So imagine the more and more you have, there's a chance that you might just have uncontrolled growth, right? Hopefully that makes a little sense. Now, thinking about this, thinking about menstruation or the menstrual cycle, the more periods someone has, the more exposed they are to estrogen. Okay, so think about that. More periods someone has, more exposed they are to estrogen. If you think about that, do you think that early menarche is the first period that you ever get, or late menarche is going to predispose you to breast and endometrial cancer? Good. I see one answer. Good. Early, right? Because, sorry, I covered the next one. But the answer is early menarche, because that means that they're going to have more periods in their life. Like if somebody started having a period at 10 versus somebody who started at 15, the person at 10 years old, or that person that had a menarche at 10 years old is going to have more periods in their lifetime. More periods means more estrogen exposure, means higher risk of endometrial and breast cancer. What about menopause? Do you have menopause early or late to increase your risk of breast and endometrial cancer? Good. Late menopause, right? Because that means that you started to have your periods ended much later in life. More periods, more estrogen, more risk of cancer. What about pregnancy? Do you think that someone who's been pregnant a lot or someone who's been pregnant never would have more risk of? Good, never. We call that nulliparity. Basically, if you've never been pregnant, you've never had a period of your life that you're not having any periods, right? Because pregnant people don't get their periods. And because of that, you've constantly had estrogen exposure. Could somebody explain to me why breastfeeding is protective for breast and endometrial cancer? Something that we talked about. What do you think breastfeeding does? How would it affect estrogen?
It inhibits gonadotropin releasing hormone.
Good. It inhibits gonadotropin releasing hormone because there's less GnRH, means less LH FSH, means less estrogen and FSH. Good. That's exactly why. Okay, and then they just tell you the symptoms of menopause. They don't mention hot flashes, but that's like a very important one in my opinion. It just means that they start to feel very warm all of a sudden. They also might get palpitations, dryness, decreased libido, poor sleep. And what they want you to know is that because of these symptoms that women get, you would think that, okay, since they're menopausal, since they have low estrogen, it's causing all these symptoms. I guess the solution is that I replace that hormone. I give them hormone replacement therapy. I give them estrogen. Problem is what we talked about before. More estrogen, more increase for breast and endometrial cancer. So it's a little bit of a trip. Exactly. It's carcinogenic. It's a little bit of a tricky thing. You have to balance it out. I don't know why he wrote cervical here, by the way. It's supposed to be endometrial. Cervical is related to HPV. But anyways. Can you re-explain the breastfeeding part? Yeah. So in breastfeeding, if you remember in our diagram, if you breastfeed, or the suckling of the nipple is going to increase the prolactin levels, right? And increased prolactin is going to decrease GnRH. Decreased GnRH means decreased LH and FSH. Decreased LH and FSH means decreased estrogen. Does that make sense? Prolactin ultimately is going to lead to decreased estrogen, and prolactin is increased during breastfeeding. Does that make sense? Okay, awesome. Okay, these two things over here that are very, very high in menopausal. So this is menopause, this is postmenopause. What are these two hormones? Super high. So estrogen increase is carcinogenic, yeah, specifically for the breast and endometrial. And again, it should make sense to you. Like, we know that estrogen stimulates these cells. So if it just goes haywire, that can lead to cancer. Does the decrease in dopamine while breastfeeding cause postpartum depression? I actually don't know. I don't know if the mechanism is well understood. That could be one theory, but I don't know that for sure. It's a good question. But yeah, you guys are right for the hormones. It's LH and FSH that's very high. And what's really, really low in postmenopausal? Estrogen. Okay, this is the last slide. I don't know how high yield it is, but I'll just like briefly explain each of these things. They're basically just telling you a bunch of contraceptive methods that you could have. First one is steroid. You've probably heard of these. They're sort of like the most common ones. It's basically estrogen and progesterone in one pill. And you can imagine, if you remember the feedback loop, if I have estrogen and progesterone, it's going to cause negative feedback inhibition. It's going to decrease GnRH. It's going to decrease LH and FSH. If I don't have LH and FSH, I'm not maturing the ovarian follicles. And because there's no maturation, there's not going to be any ovulation. If there's no ovulation, there's no oocyte, there's nothing to fertilize, basically. Is that clear, like how steroid contraceptives work? They basically inhibit GnRH. It's just the normal. Yeah, I can re-explain it. So inside of a contraceptive pill, I have estrogen and progesterone. Okay. And remember, I don't know if I have a diagram of it, but just remember the feedback loop of estrogen and progesterone, right? In this case, if you can imagine, I have high, like instead of decrease, it would be high estrogen. If I have high estrogen, it's going to cause negative feedback inhibition. That's going to decrease the GnRH. Decrease GnRH means decrease LH and FSH. Decrease LH and FSH means less ovarian follicle development. Less ovarian follicle development means no oocyte. No oocyte means that there's nothing to fertilize. Does that make sense? Okay. And the other ones are like quite easy. IUD, sometimes they can have progesterone, which is the exact same mechanism that I just explained. Sometimes they can have copper. Basically, what copper does is that it's going to really irritate the uteral lining. And because it's so irritated, the uteral lining is going to start secreting these very thick secretions. And those very thick secretions are going to make it very hard for the blastocyst to implant. So that's how IUDs work. They just really irritate the uterine lining and make it hard for implantation. Barrier methods, I'm sure you know, they just prevent the sperm from getting into the vaginal canal or inside the uterus. Sterilization is a permanent method. In women, what it means is that you tie the fallopian tubes. You might hear the term like she got her tube tied. That means that they tie the fallopian tube. That means that if the oocyte is released in the fallopian tube, it's not going to be able to actually get into the uterus, right? It's like you can do the same in males as well, where you do a vasectomy and you just prevent the sperm from leaving. The next one is abortive methods. Basically, this is after, for example, the blastocyst has already implanted. So what you're going to do is you're just going to prevent the uterus from creating a nice environment for the embryo. In other words, you're going to prevent progesterone, because remember, progesterone usually supports the embryo development. Over here, we're doing the opposite. we're preventing embryo development by giving anti-progesterone therapy. So abortive anti-progesterone therapy. And that's going to sort of like expel the embryo because it can't implant or it can't stay. And the last one is very interesting, and it's not something that I think is very reliable, but there actually is a temperature change when a woman is ovulating. And if you're very, very, very good at tracking your menstrual cycle, you'll actually know the exact date that it's expected on. So basically what you can do is that you can look at the dates and you can calculate based off of your last period, where am I expected to ovulate? And on top of that, you can also measure your temperature. And if your temperature increases by 0.5 degree or a degree, it's likely that you might be ovulating. And so based off of that, you could just sort of not have sexual intercourse during the period that you're ovulating. And that means that there's no chance, theoretically, of an egg getting fertilized. But you can imagine this isn't really like super reliable because periods are very irregular. Increase in temperature can be due to a million things, especially if we're talking about like 0.5 degree. So it's not very reliable. Any questions about any of the contraceptive methods? All clear? Okay. The most important, I would say, is at least understand the negative feedback of the steroid one. That is it. This is a QR code for feedback. Again, you can give me feedback also through email or through text. Even if it's negative, I still want to hear it. I'm sorry that I took so long. I tried to make it shorter, but yeah. How does estrogen increase during labor?